Hi there. I welcome you to this short course on basic radiobiology. This is the third lecture, and in this lecture, we will look at radiation effects, fractionation, and the 4 hours of radiation therapy. The organs at risk could be classified in three different ways. It could be serial organ, or it could be parallel organ, or it could be serial as well as parallel organ. Let us look a little more closely into what is a serial organ and what is a parallel organ. As a physicist, I would like to explain you with reference to our serial and parallel circuitry. You know very well in a serial architecture, you have, for example, three bulbs here. If one of the bulbs is fused, the entire serial architecture will not be working. So everything is gone. However, in a parallel architecture, if one of the bulbs get fused, still the other two bulbs here would work. It is very similar thing here. If one subunit is spoiled in that organ, if it is a serial architecture, the entire organ will not work. The destruction of one subunit results in the complete breakdown of the global function of the organ. So that is called the serial architecture. In the parallel architecture, if one of the subunits is broken or damaged, the organ will have its functional capability. It will still keep functioning. Let us look at an example of serial and parallel organ. Kidney is a good example of parallel architecture or parallel organ. The subunit of kidney is called a nephron, and these nephrons act independently. They function independently of each other. Therefore, if one nephron is damaged or one subunit is damaged, the other nephrons function normally, or the other subunits function normally. Spinal cord is a classical example of an organ with serial architecture. Damage to even a small section of the spinal cord will result in the loss of function of the entire spinal cord. Even sections distal to it will not function if a small section of the spinal cord is damaged. Both architectures, serial and parallel, are sometimes combined in the same organ. This is because different tissues cooperate to a common function. A good example is lung. It has a parallel architecture at the level of parenchyma, where gas exchanges take place. On the other hand, airways carrying air in and out of the alveoli have a serial arrangement, serial architecture. In the previous slides, we looked at the classification of organs depending on the radiation effect. Now we will look at the classification of radiation effects. There are two different ways we classify radiation effects. One depending on who is affected. The second depending on what is the type of effect. First we will look at the first one, which has two different classifications. One is called somatic effect or the hereditary effect. Somatic effect affects the health of the exposed individual. Hereditary effect occurs in the descendants of the exposed individual. These are also called genetic effect, which happens in the descendants, or we can say offsprings of the exposed individual. The other classification of radiation effect depending on the type of effect is stochastic effect, otherwise called non-stochastic. They called it deterministic earlier. Now they call it tissue reaction. We look at both stochastic and deterministic, which is now called tissue reaction. Stochastic effects are effects for which the probability of an effect occurring rather than its severity is regarded as a function of dose with no threshold. Example, range of solid tumors as well as leukemia. We will look at little more closely in the next slides. Non-stochastic effect or deterministic effect, otherwise called the tissue reaction, are those which become evident after a large dose. There is a threshold below which the effects do not occur. There is a minimum dose. Erythema, reddening of the skin, or have a minimum dose of 3 sieverts. These are deterministic effects. We will look at stochastic effect. Stochastic effect pertains to random process, by which we mean if several people get exposed to a dose, doesn't mean everybody will get a stochastic effect. We won't be able to say who will get it. It's a very random process. There is no threshold dose. There is no minimum dose. Severity is independent of dose. Getting higher dose does not mean one will get a severe effect. The severity is independent of dose. Even with a smaller dose, the effect could be severe. But the probability depends on the dose. So if one gets very high dose, then the chances of stochastic effect is higher, probability is higher. Stochastic effects are late effects and the good examples of carcinogenesis and genetic effect. Here are some examples of stochastic effect: leukemia, bone cancer, thyroid cancer, lung cancer. I have given you here the mean latent period. What is latent period? Latent period is the time between the exposure and the effect appearing. So I did say most of the stochastic effects are late effects. Leukemia takes about 8 to 10 years to manifest as an effect after exposure. The evidence is some atomic bomb casualties. Bone cancer takes about 15 years. That is dial painters. Thyroid cancer takes 15 to 30 years, again atomic bomb casualties. Lung cancer takes 10 to 20 years, these are mine workers, right? So this is the latent period, that is the time between exposure and actually the effect happening. This varies significantly. This is not a very accurate values because each book will give you slightly different values, but this has real meaning that leukemia sometimes takes 8 to 10 years to show it off after radiation. Similarly, bone cancer, thyroid cancer and lung cancer. Let us look at deterministic effect. We can call it tissue reaction. Now, as I said, it's non-stochastic effect. This has a threshold, that is, there is a minimum dose. If one does not get that minimum dose, then that effect will not appear. So if a person gets a dose of this level, for example, at this level, then that effect will not happen. So one has to get that minimum dose for the effect to appear. Severity depends on the dose. If one gets higher doses, it becomes very severe and it's early effect. It's not late effect, it's early effect. Example is cataract. Cataract is a very good example of radiation because cataract is the one you can easily say it is radiation induced cataract. Erythema, reddening of the skin, epilation, loss of hair. These are examples of tissue reaction or deterministic effect. After having studied radiation effects, we will look at the dose response curve. First, we will look at the dose response curve for a normal tissue. The response of normal tissue to radiation is mostly deterministic effect, which means you can see that it happens after certain dose. Right? This response follows a sigmoidal shape. As you can see, it follows a sigmoidal shape, and the steep part of the slope indicates that the region where a small change in dose may have a large change in toxicity. If you increase the dose slightly here, then the normal tissue complication probability, that is the NTCP values, increases. So even a small change in dose can have a large increase in normal tissue complication probability. The dose response curve for tumor also follows a sigmoidal shape. The steep part of the curve, as you can see here, a small change in dose may compromise on the tumor control probability, TCP. So if you have a little lower dose than it is required, there could be a significant compromise to the tumor control probability. It's exactly opposite to what I said in the previous slide. If there is a small increase of dose, normal tissue complication probability will increase. Here, where a small decrease in dose will result in compromise on the tumor control probability. The normal tissue complication probability curve and the tumor control probability curve, these two curves come close to each other. This actually results in a compromise in a radiotherapy. So there is a compromise between cure and acceptable risk. For example, in this graph, you can see if you take a 70% cure, you result in about 5% of normal tissue complication. But if you choose a 90% cure, you result in about 20% of normal tissue complication. So it's a trade-off between the tumor control and the normal tissue complication. The idea of compromise between normal tissue complication probability and the tumor control probability have brought in a concept called therapeutic ratio. Therapeutic ratio is the ratio of dose D2 by D1, where D2 is the dose required to produce serious complications in 50% of the patients, whereas D1 is the dose required to have tumor control in the same 50% of the patients. The therapeutic ratio, that is D2 by D1, should be greater than 1. If it is much larger than 1, it's good for radiotherapy. For that purpose, one would like to have the tumor control probability curve move this way and the normal tissue complication probability curve move in this direction. One of the ways to improve the therapeutic ratio is fractionation. Some of the DNA damage produced by first fraction of radiation can be repaired before the second fraction, provided enough time is given between the fractions so that the repair can take place. That is, approximately you have to give 6 to 24 hours depending on the tissue under consideration. If you look at the graph here, that shows the survival increases when you give by 2 fraction. For example, if you give single fraction, a particular amount of dose, the survival comes up to here. This is the survival that is left. Whereas you do the same thing by 2 fractions, then for the same dose, the survival curve is here. That means this is the gain due to repair between the first and the second fraction. This much of survival is the gain because of the repair between the first and the second fraction. What should be the time between fractions? We said sufficient time interval between fractions should be given so that repair of sublethal damage from the first dose can be completed before the next dose is delivered. Usually, the interfraction interval is about 6 hours. You can have a question in your mind, why minimum of 6 hours between fractions? Why not it could be different? That is, in the 6 hours, it is assumed that 90% of the normal cells would recover. That is because the half-life of recovery of cells from radiation damage is approximately 1.5 hours in average. So, if you take 4 half-lives, that is approximately 6 hours, 90% of the cells would recover. Let us look at the fractionation and how it helps the repair. Different tissues have different fractionation sensitivity related to their capacity to repair DNA radiation damage. Early responding tissues have a limited DNA repair capacity, whereas late responding tissues have a large DNA repair capacity. Thus, the tolerance dose of early responding tissue is moderately affected by variation in fraction size in the range of 1.5 to 4 gray. So the tolerance dose is not very much affected in the case of early responding tissues. The tolerance dose of late responding tissues, on the other hand, varies greatly with the fraction size. The number of cells that repair the DNA damage between consecutive fractions depends on the repair capacity. In the last slide, we saw early responding tissues have a very limited repair capability or small repair capability, whereas the late responding tissues have large repair capability. So if you look at this graph, if you increase the number of fractions from 3 to 6 for small repair capability, that is the early responding tissues, the gain you get is very little. Whereas in the case of cells that have large repair capability, if you increase the number of fractions from 3 to 6, the gain is significant. What are the advantages and disadvantages of fractionation? The advantages of prolonged treatment or the fractionation, it spares early reactions, allows adequate reoxygenation in tumor. The disadvantages are it can decrease deceptively the acute reaction without sparing the late injury. It allows the surviving cells, tumor cells, to proliferate during treatment. So if you prolong the treatment, this could happen. There could be a proliferation of the tumor cells during treatment, and it can decrease the acute reaction without sparing the late injury. At the same time, the advantages are spares early reaction. The early reaction could be much less, allows adequate reoxygenation between the fractions in the tumor. There are several fractionation strategies that are being used in radiation therapy. One is hyperfractionation, accelerated treatment, continuous hyperfractionated accelerated radiotherapy, otherwise called the CHART, and hypofractionation. What is hyperfractionation? The hyperfractionation actually is classified into two. One is pure hyperfractionation, the other one is impure hyperfractionation. And I think most of us work on this impure hyperfractionation. The pure hyperfractionation has more than one fraction a day, but same total dose as in conventional regimen in the same overall time. So the overall time is the same like a conventional fractionation scheme and the same total dose, but it has more than one fraction a day. Impure hyperfractionation increase in total dose, more than one fraction a day, sometimes increase in the overall time. But most of the time it is an increase in the total dose and it is an increase in the number of fractions per day. So this will normally form the hyperfractionation. So what is the intent of hyperfractionation? It reduces the late effects, achieves the same or better tumor control, same or slightly increased early effects. There is an example in EORTC study 22791. They had a conventional 2 gray per fraction and 1 fraction a day over 7 weeks and hyperfractionation of 1.15 gray per fraction and 2 fractions a day over 7 weeks. They found an increase in the local tumor control from 40% to 59% at 5 years of survival. Accelerated treatment is slightly different. Here also we can say there are two different types. One is the pure accelerated treatment. Same total dose as conventional treatment delivered in half the overall time. However, acute effects become the limiting factor and hence a rest period in the middle of the treatment may be required, or to reduce the dose slightly with the acute effects as the limiting factor. So either you reduce the dose or you give a gap in between the treatments so that the acute effects become less. The intent is to reduce repopulation in rapidly proliferating tumor cells, little or no change in the late effects. Let us look at what is CHART, which I said earlier as the continuous hyperfractionated accelerated radiotherapy. You use low dose per fraction here. Short overall time, the overall time reduces because it is accelerated. 3 fractions a day because it is hyperfractionation. The results of CHART are you get good local tumor control owing to short overall time, acute reactions that are brisk but peak after treatment is completed. The acute reactions actually take place after the treatment is completed because the treatment is quite short. Acceptable late effects due to small dose per fraction. The late effects are acceptable because your dose per fraction is reduced. Let us now look at hypofractionation. Hypofractionated radiotherapy is the delivery of fewer larger doses greater than 2 gray. That is high dose per fraction, therefore higher cell kill but increased late effects. This was originally performed for palliative treatments so that you can finish the treatment faster and send the patient home. However, there is a return of this hypofractionation due to increased interest in low alpha beta tumors such as prostate, and nowadays it's more feasible as a result of decreasing radiotherapy volume that allows more conformal radiotherapy delivery and limit the dose delivered to normal tissue. And Very good example is IMRT, where highly conformal dose could be delivered so that the tumor gets high dose and normal tissues get very low dose. This is an interesting graph. I just included it to give you some idea about the fractional effect. In this graph, you have the dose per fraction plotted against the inverse of total dose. This is inverse of total dose and this is dose per fraction. If you look at for 2 kilorads per fraction, you have to give out approximately about some 30,000 rads or 3 kilorads to get a certain effect. But when you go to 1 kilorads per fraction, you have to give much more, approximately around 4,000 rads, that is 4 kilorads, to get the same effect. This is something like an ISO effect, same effect plot between dose per fraction in kilorads and inverse of the total dose, that is 0.1, 0.2, 0.3. If you extrapolate this graph and it meets its y-axis, and the dose will be, to get the same effect, the dose will be approximately, let me say in this case, about 8 to 9,000. What does it mean? With almost zero dose per fraction, you need 8 to 9,000 to get the same effect. This is a little bit of a questioning thing in mind. What is zero dose per fraction? It is actually not zero dose. It is explained as infinitely small amount of dose in infinite number of fractions. It's like something like a brachytherapy. This extrapolated and which meets the y-axis and gives a dose value is called the extrapolated response dose, ERD. This was originally the start of the LQ model, which later on the ERD became BED, biological equivalent dose. So this is the start of that ERD, which is the fractional effect plot, otherwise called the FE plot. Let us now look at the 4 R's of radiotherapy. By definition, these are the most important biological factors that influence the response of tumor and normal tissues to fractionated treatment. We call them as 4 R's of radiotherapy. This was suggested by R. Withers in 1975. The 4 influencing biological factors are reoxygenation, redistribution, repair, and repopulation or regeneration. Let us look at reoxygenation. Oxygen is an important factor for enhancement of radiation effect. We saw that in our previous lecture itself. Oxygen enhancement ratio, particularly for low LET radiation, the presence of oxygen enhances the radiation effect. The tumor may be hypoxic, particularly in the center, which may not be well supplied with blood. So if it has become aerated, then there will be an oxygen effect. One must allow the tumor to reoxygenate, which typically happens a couple of days after the first fraction. So if you give a small gap, then it reoxygenates and it becomes more radiosensitive. The next one is redistribution. Cells have different radiation sensitivities in different parts of the cell cycle. This we discussed in the very first lecture also, and it's the same thing we are going to repeat. Cells are most sensitive at or close to mitosis. That's here. Resistance is usually greatest in the later part of S phase. If G1 phase has appreciable length, a resistant period is evident early in G1. This is resistant period, followed by a sensitive period at the end of G1. G2 is usually sensitive, perhaps as sensitive as the M phase, that is the mitosis. The distribution of cells in different phases of the cell cycle is normally not something that we can influence it or can be influenced. However, radiation itself introduces a block of cells in G2 phase, which leads to asynchronization. So one must consider this when irradiating cells with break of few hours. One must consider this redistribution that happens. The next one is repair. Cells repair radiation damage. All cells repair radiation damage. This is part of a normal repair process. Repair is very effective because DNA is damaged significantly due to normal other influences such as temperature and chemicals than due to radiation, which is a factor of, actually the difference is a factor of 1000. The half time of repair is in the order of about minutes to hours, which we have discussed earlier also. We will see it little more again. It is essential to allow normal tissues to repair all repairable radiation damage prior to giving the second fraction. So between fractions, you should allow the cells to repair all repairable damage. This leads to a minimum interval of about 6 hours, which we discussed. Why 6 hours also we discussed, right? The half time is average, half time is 1.5 hours. So if you allow 4 half lives, so it is approximately 6 hours. However, for spinal cord seems to have particularly low repair. Therefore, breaks between fractions should be at least 8 hours if you are including spinal cord in the treatment. Next is repopulation. Cells also grow during radiotherapy. For tumor cells, this repopulation partially counteracts the cell killing effect of radiotherapy, which means as you keep killing cells with radiation, there is repopulation also happening. It actually counteracts your effort to kill the tumor cells. The potential doubling time of tumor, that is, as it repopulates, it becomes double. The time that it takes to double the quantity, that is the TP, in case of head and neck tumors and cervix, can be as short as 2 days. So one can lose up to 1 gray worth of cell killing by prolonging the course of radiotherapy. The other thing about repopulation is the repopulation time of tumor cells is not constant. It appears to vary during radiotherapy. At the commencement, it may be very slow due to hypoxia. However, a certain time after the first fraction of radiotherapy, repopulation accelerates. This particular time is called the kick-off time. Repopulation must be taken into account when protracting radiation, particularly due to scheduled breaks or unscheduled breaks such as holidays. It is not only the tumor cells that repopulate, it is also the normal tissues repopulate. This is an important mechanism to reduce acute side effects from, example, the irradiation of skin or mucosa. Radiation schedules must allow sufficient regeneration time for acutely reacting tissues. When you do a radiation schedule, you should allow adequate time for regeneration of acutely reacting tissues. Thank you very much for listening to this lecture. I hope it was useful and you can enjoy the lecture. As usual, there are some MCQs. Please do them before you proceed further.